There should be plenty of time in the lecture for questions. So feel free to ask and speak up, and we can backtrack over previous slides. There's going to be some advanced topics discussed here, so feel free to intervene if you're confused by anything or want to rehash anything. That's totally fine. We'll have plenty of time. Okay, so let's get started. My name is Bobby Whitford, and I'm a second-year critical care fellow in the Department of Anesthesia here at the University of Colorado. My background is emergency medicine. I did a 4-year ED residency at the University of Cincinnati, and I think we may even have some Cincinnatians on in the talk today. Welcome, Adam. Good to have you. And today I have the privilege of giving our critical care ultrasound lecture, the topic of which will be echo-guided shock diagnosis and resuscitation, i.e. how to turn your echo probe into a swan. So echo has been utilized for shock diagnosis and management. The RUS protocol is one method that has been around since the late 2000s, and it stands for the Rapid Ultrasound and Shock Exam, and involves performing a limited echo, an IVC exam, an extended fast exam, and an abdominal aorta exam. The protocol uses these modalities to qualitatively evaluate the status of the pump, the tank, and the pipes to help establish an etiology of your patient's shock. The protocol is popular and simple to use, however, has many limitations. First, it advocates for using the IVC to evaluate the status of the tank and the need for IV fluid. However, it's important to realize that a small IVC does not distinguish between a low preload versus a low afterload state, for which a vasopressor rather than fluid is the appropriate intervention. Secondly, performing an extended fast or AAA exam in a person with no indication of a low CVP is a poor investment of your time and akin to a shotgun approach to ultrasound. In addition, even if free fluid is found to be in the abdomen or the thorax, this does not equate to hypovolemia. Likewise, the presence of a pericardial effusion or pneumothorax doesn't diagnose tamponade or a tense pneumothorax. Indeed, the ultrasonographic diagnosis of tamponade is actually quite nuanced and the subject of a separate lecture. And lastly, the exam's assessment of the LV and RV function are somewhat cursory with potential for error, and no assessment is made of the stroke volume, the cardiac output, or of the patient's response to interventions. The Swan catheter, or the pulmonary arterial catheter, was developed in the 1970s and for several decades was the standard of care for hemodynamic management of critically ill patients. However, in the 2000s, its routine use fell out of favor as evidence began to accumulate that when utilized indiscriminately in a primarily septic patient population, that it did not improve patient outcomes. In addition, there are several potential complications, many of which can be fatal, such as RV free wall or pulmonary artery rupture. The Swan provides direct measurements of the CVP, or the right atrial pressure, the WEDS, or the pulmonary artery occlusion pressure, and can provide direct cardiac output measurement via thermodilution techniques, and from these calculate the systemic vascular resistance. Using these variables, we can categorize our patient's shock state. Notice that I do not include sepsis on this table because sepsis is a mixed shock state. Patients can present with hypovolemia from venodilation as well as third spacing and will have a reduced cardiac output. However, after resuscitation with IV fluids, they may also have a distributive shock state from arterial and capillary bed vasodilation and an elevated cardiac output. Furthermore, later on, some can develop a stress cardiomyopathy and with resultant LV or RV failure and develop cardiogenic shock and a reduced cardiac output. Now, if we eliminate SVR from this table, we still have enough information to categorize our patient's shock state. And so in this lecture, we will discuss how to utilize ultrasound to estimate your CVP using the IVC, the wedge pressure using the left ventricular end diastolic volume, and the cardiac output using the left ventricular outflow tract VTI, or LVOT VTI. So my approach to shock ultrasound is 3 steps. First, I obtain an image of the IVC in its long axis to estimate the patient's CVP. Now, there are many pitfalls to IVC evaluation, which we will go through shortly. Second, I obtain an apical forward chamber view to assess biventricular size and function, paying special attention to imaging the RV adequately. While here, I will also assess the left ventricular end diastolic volume for an LV preload assessment, which at extremes of physiology, we can often just eyeball, but in more subtle cases, it is useful to quantify using Simpson's method. And while here, we will also evaluate for the presence or absence of a pericardial effusion. And as stated before, tamponade is largely a clinical diagnosis. The ultrasonographic diagnosis of tamponade is quite nuanced and is the topic of a separate lecture. And lastly, we will decrease the angle of our probe slightly to obtain the apical 5-chamber view and see the left ventricular outflow tract and measure the VTI for a cardiac output assessment. So my approach to image interpretation, once we've obtained these 3 variables, we can diagnose our patient's shock state. If the patient's CVP is low and they have a low left ventricular end diastolic volume and a low cardiac output, that is consistent with hypovolemia, in which case I might also consider doing an extended vascular exam to evaluate for free fluid in the thorax or the abdomen, as well as an abdominal aortic aneurysm exam in the right clinical context, and perhaps even a rectal exam, because unfortunately we have not yet found a way to use ultrasound to replace this. If the CVP is low and they have a normal left ventricular end diastolic volume with a high cardiac output, that is consistent with a distributive shock case. If they have a high CVP but a low cardiac output and either reduced LV or RV function, that would be more consistent with LV or RV failure and cardiogenic shock. And if the CVP is high and they have a low cardiac output but normal biventricular function and no evidence of tamponade, then I would go to evaluate for lung sliding, as that patient may have a tension pneumothorax. Now, tension pneumothorax in a spontaneously breathing patient is primarily a disease of progressive hypoxemic respiratory failure, and usually does not develop hypotension up until the point that they have a cardiac arrest. Intubated patients, however, on the other hand, will develop hypotension and a reduced cardiac output much earlier on. Okay, now let's talk about IVC ultrasound. So the IVC can be used to estimate a patient's CVP. To do this, we will need to measure this IVC's diameter and its percent of collapsibility. Our measurement is performed just distal to the insertion of the hepatic vein, and all we really need to know is whether or not the IVC is greater than or less than 2 centimeters. Now, and then with collapse, we want to know whether or not the collapse occurs as less than 50% or greater than 50%. Now, in a spontaneously breathing patient, inspiration will pull blood into the pulmonary circulation, causing the IVC to decrease in size. So if the IVC is greater than 2 centimeters, and with inspiration we see a collapse of less than 50%, then that would indicate a CVP estimate of 15. On the other hand, if we have an IVC which is less than 2 centimeters and collapse is greater than 50% with inspiration, that is consistent with a right atrial pressure of 3. Now, it's important to recognize that positive pressure ventilation from mechanical ventilation will reverse the pattern of respirophasic variation. Inspiration will distend the IVC rather than collapse it, and so our estimation of CVP is limited. You'll notice that when cardiology interprets an echo on a mechanically ventilated patient, they generally won't comment on the CVP, and sometimes the technician won't even image the NIVC. However, if despite mechanical ventilation, the patient's IVC is still small and collapsible, that is fairly sensitive for a low CVP stage. And now it's important to emphasize that we are using CVP to help us categorize a patient's shock state, not to help us decide whether a fluid bolus is appropriate, as the CVP has been studied extensively and shown to not be a reliable predictor of volume responsiveness. And as mentioned earlier, a low CVP does not distinguish between a low preload versus a low afterload state. It's also important to appreciate that there are many potential confounders in IVC interpretation. We already discussed the effects of positive pressure ventilation, which will tend to increase the IVC diameter and thus the CVP. In addition, patients with chronic competent heart failure may always have an enlarged IVC, yet can also present with hypovolemic or distributive shock. And the IVC may also appear small despite an elevated CVP due to increased intra-abdominal pressure, which could occur due to large volume ascites, pregnancy, volume overload, or abdominal compartment syndrome. In addition, some patients in cardiogenic shock may have a normal appearing IVC because they have a normal CVP. A patient who is euvolemic prior to having their the acute anterior STEMI will still have a normal CVP and may have a small or collapsible IVC. Okay, so some tips for IVC image acquisition. If you can't obtain an accurate subcostal window due to bowel gas or bandages, slide laterally to your right upper quadrant fast view. And do not mistake the aorta for the IVC. This is a common error in IVC interrogation. If it's not visible, it may be that it's fully collapsed, in which case you can trace the hepatic vein down to where the IVC should be. And when measuring the overall size at its largest, I like to do this quantitatively by freezing the image and using calipers. But when assessing the percentage of collapse, I think it's fine to do that qualitatively. So in summary, we must be cautious with our IVC interpretation as there is potential for significant intra-provider variability. I have had 3 providers come to me with 3 different recommendations based on the same IVC images in the same day. So I think it's very important to do some quantitative assessment of it. And the IVC in isolation is essentially useless. We have to examine the heart, the lungs, and put it all in the clinical context in order to make useful clinical predictions. And remember that we're not using the IVC as a surrogate, that we're using the IVC as a surrogate for CVP to categorize shock, not for volume responsiveness. Just because someone has a small IVC does not necessarily mean they need more fluid. They may actually benefit more from a vasopressor. All right, let's move on and talk about echo. So echocardiography can be used to distinguish between low preload versus low afterload states using the end diastolic volume and the end systolic volume. In this diagram, we have a schematic of the left ventricle and short axis. And in a normal physiologic state, the heart ejects about 65% of its volume, and your end diastolic volume should appear like this, and end systolic is not completely empty. Now, in patients with a pure low afterload state, low systemic vascular resistance from distributive shock, they will have a normal end diastolic volume, but a reduced end systolic volume. This end systolic volume being reduced is sometimes referred to as a hyperdynamic ventricle, where at the end of systole, you see effacement of the ventricular walls, and they can almost touch each other. However, this reduced end systolic volume, or this hyperdynamic left ventricle, does not distinguish between a preload or an afterload problem. What does is the end diastolic volume. A patient with a pure preload problem from hypovolemia will have a reduced end diastolic volume, as opposed to the patient with an afterload problem from distributive shock will have a normal end diastolic volume. Now, at extremes of physiology, I think we can oftentimes get away with eyeballing this end diastolic volume and making an assessment. But in more subtle cases, I think it's important to quantify this using Simpson's method. So once again, a reduced end diastolic volume may be a patient who's hypovolemic and needs more preload. But remember, the preload can be given with fluids, but don't forget that vasopressors also improve our preload, as they not only squeeze down on our afterload vessels, but they squeeze on the capacitance vessels as well. If you have a pure afterload problem with a normal end diastolic volume, then a vasopressor would be appropriate. And don't forget that just because you have a reduced left ventricular end diastolic volume, that does not necessarily mean the patient has a reduced preload due to due to hypovolemia. This could also represent RV failure, as the RV is not able to get blood across the pulmonary circulation into the LV effectively. And we'll discuss that more shortly. Okay, so yeah, this term hyperdynamic, I think it's thrown around a lot, so I think it's useful that we really clarify what this means. And the technical definition is this left ventricular end systolic effacement, or this kissing of the left ventricular walls at the end of systole. And being hyperdynamic should not be confused with being tachycardic. You can certainly be tachycardic and not hyperdynamic, and you can be bradycardic and hyperdynamic. So they're not the same. In addition, as stated earlier, a hyperdynamic heart does not distinguish between a hypovolemic state, a distributive state, or RV failure. And there's also different degrees of hyperdynamism. You could have effacement involving just the apex. In more severe cases, it may involve the mid segments, and in more severe cases, it may involve the basal segments as well. And be careful, because foreshortening of the left ventricular cavity can cause the illusion of this as well. So as stated earlier, oftentimes we can eyeball the end diastolic volume. However, with less obvious cases, the left ventricular end diastolic volume should be quantified using Simpson's method of discs. Most machines should have the software package to do this. So the left ventricle is traced out, and the machine will integrate the area using these discs to calculate the volume. And this can also be done at the end of systole to formally calculate the patient's ejection fraction and the degree of LV dysfunction. However, in practice, most experienced sonographers, rather than formally calculating an EF, when assessing overall LV function, will just eyeball it. However, if you really want to know the end diastolic volume for a shock assessment, I think it is useful to measure that volume formally. Now, for left ventricular end diastolic volume quantification, we have to reference our normal values for age and gender. For a male between the ages of 40 and 60, the end diastolic volume should be about 130 milliliters, plus or minus a standard deviation of 25. And for a female of the same age, it should be 100 plus or minus 20. And you'll notice that for younger patients and older patients, these values will increase or decrease respectively. Now, RV function evaluation can be quite nuanced and is the topic of a separate lecture. However, briefly, we should be evaluating for right ventricular dilation, right ventricular hypokinesis, which we can characterize with a TAPSE or a fractional area of change. We want to look for interventricular septal flattening or the D sign. We want to evaluate for that IVC plethora, tricuspid regurgitation, as well as right ventricular outflow tract Doppler flow patterns. This is an active area of research that I'm contributing to, and there's emerging evidence that these flow patterns can help distinguish between different causes of RV failure, such as acute PE, right ventricular MI, and different classes of pulmonary hypertension. Okay, moving on to cardiac output assessment. So to measure the cardiac output, we must first imagine that the stroke volume is a cylinder of blood that is ejected across the left ventricular outflow tract. The length of this cylinder is the distance blood travels during systole and is calculated using the velocity time integral, or the VTI. The area of the cylinder is pi r squared, where r is the radius of the left ventricular outflow tract. The LVOT VTI is measured in the apical 5 window by placing your pulse wave Doppler just behind the aortic valve in the outflow tract. And we'll get an image which looks like this. Now we trace the parabola and the machine will integrate the velocity over time, providing us with a distance in centimeters. Next, we measure the LVOT diameter, which is done in the peripheral long axis view. And using this, we can now calculate the stroke volume. However, a quicker way to estimate the stroke volume is to simply multiply the LVOT VTI by 3. As for most people, the LVOT diameter is about 2 centimeters. And so the radius of that is 1, which if you square is just 1. So essentially just multiplying the VTI by pi, which is approximately 3. But in most situations, we can simplify things even further and just measure the LVOT VTI and use that as the surrogate for cardiac output. And we can reference the normal ranges for males and females. A male should have an LVOT VTI of approximately 20 plus or minus a standard deviation of 3, and a woman about 21.5 plus or minus 3. Now there are some assumptions that go into this, such that the LVOT area is constant, which for the most part is true, and that the heart rate is within a fairly normal range of 60 to 100. If you're outside of those parameters, I would go ahead and do the formal LVOT measurement and heart rate calculation to get a formal cardiac output measurement. There are also exceptions to this VTI rule as a surrogate because the VTI can be falsely high in a couple of scenarios, such as with dynamic LVOT obstruction from severe hypovolemia, HOCM, or an acute anterior STEMI. And if you have aortic insufficiency, your cardiac output may appear elevated based on your VTI, but remember that aortic regurg is not being subtracted from that measurement, so your overall cardiac output may actually be quite low. There are also some limitations. First of all, spectral Doppler is technically an advanced echo exam, and most credentialing bodies would recommend having performed about 150 of these to gain proficiency. In addition, the angle of insonation can lead to an underestimation of the VTI. So in this diagram, the blood is flowing this direction across the LVOT, but the angle of the probe beam is coming in not directly parallel to the blood flow. Now, in general, as long as this angle of inclination is less than 20 degrees, you'll be fairly accurate. But once it's greater than that, you quickly lose accuracy and will underestimate your VTI. Though it's important to appreciate that you will never overestimate the VTI. Of course, there's always the potential for user error, patient factors, and machine problems. A question that sometimes comes up is, why not just use the carotid VTI? Well, the carotid is easier to obtain, but the diameter needs to be constant in order for us to rely on changes in VTI as surrogates for changes in cardiac output. And unfortunately, the carotid diameter does change with flow, and this is known as flow-mediated vasodilation. Now, with all that in mind, let's go ahead and move on to our cases. Any questions so far?
That was a very comprehensive review of all the different modalities. So it'll be interesting to look at the cases.
Thank you. Okay, let's do it. So case one, this is a 60-year-old female who was pedestrian struck, suffering polytrauma. She presented hemodynamically stable with a ZCS of 14 and significant orofacial trauma and oral bleeding. She was intubated for airway protection, and CT revealed she had a small retroperitoneal hematoma, multiple rib fractures but no pneumo or hemothorax, and a grade 1 liver laceration, as well as multiple facial fractures but no intracerebral hemorrhage. She arrived to the ICU intubated with a normal blood pressure and heart rate. 2 hours after arrival, however, her blood pressure is 60/30 and her heart rate is 105, and her pulse ox is no longer registering. Sorry, these images may take a moment to load. The left image is her IVC, which is completely effaced. You cannot see it because it's fully collapsed down. And remember, this is an intubated patient. So technically, one would say that we cannot comment on the CVP estimate based on this. But as stated, the IVC in an intubated patient should tend to be enlarged. And so the fact that here it is completely effaced is suggestive of a low CVP state. And in our image on the right, we have a subcostal apical 5-chamber view. And I think you'll be able to appreciate that this left ventricular cavity is completely empty. At the end of diastole, it's marginally filled at best. So this one's kind of a no-brainer. She gets massively transfused. And post-MTP, you can see her IVC on the left is nice and plump, as we would expect in an intubated patient. And her apical, or her forward chamber view of the heart reveals that both of her chambers seem filled, and her left ventricular end diastolic volume is grossly normal at this point. She was not bleeding into the thorax or the abdomen, so we were able to assume that it was her retroperitoneal hematoma that was enlarging, though given her hemodynamic stability after transfusion, she was not taken for empiric angioembolization. Any questions about case one? Okay, moving on to case two. This is a 20-year-old male who was in a motorcycle crash, suffering a traumatic left lower extremity amputation. He had a massive right hemothorax that put out about 1.5 liters of blood upon chest tube placement. So he was taken to the operating room where he underwent a right posterior lateral thoracotomy and had an intercostal artery that was ligated. He also suffered a T8 trans fracture with complete cord transection and resultant flaccid lower extremities. He was transferred from the Outset Hospital on post-op day 1 for a spine consultation. He arrived to the ICU intubated on norepinephrine at 0.15, and that's in micrograms per kilogram per minute. So for those of you who are not using weight-based dosing, if you just move over the decimal a couple of spots, it's about 15 micrograms per minute, and vasopressin of 0.04 micrograms a minute. And this was reported from the transport crew to be thought that it was due to neurogenic shock, was the report that they received from the transferring hospital. So our question now is this indeed neurogenic shock? Could there be an occult hemorrhagic or an obstructive component? So here is his IVC on arrival. It's kind of mid-range, not very collapsible. Once again, this is an intubated patient, so we can't really draw much conclusion about the CVP from that. It may be high, it may be low. And on the right, we see a forward chamber view of the heart. This is kind of a modified apical view. You can see we're looking through the subcostal window because we have liver here, because he did not have any apical windows truly. Everything was displaced quite inferiorly. But we're able to get an adequate forward chamber view from the subcostal window. And the left ventricle may be underfilled, but it's not quite as evident as it was in the previous case. And so in this case, we did a formal Simpson's method evaluation of the left ventricular end diastolic volume, and we get a value of 54 milliliters, compared to a male of this stage should have an end diastolic volume of about 140 milliliters. So this is very suggestive of a low left ventricular end diastolic pressure and volume. In addition, we measure his LVOT VTI and find it's quite reduced at 13 centimeters. So he has a possibly high or low CVP. We know he has a low preload and a reduced cardiac output. This is all consistent with a hypovolemic shock picture. And so the patient is bolused fluid and given blood, following which a repeat evaluation of the IVC is seen on the left, and a repeat apical 4. You can see that his left ventricular volume does appear more full, and when we measure that, it is increased to 81 milliliters, and his VTI reassessment is improved to 18 centimeters. Which now begs the question, why is our patient so hypovolemic? At this point, we go on to repeated chest x-ray. Now you can see that he has 1 and 2 surgical chest tubes on the right that were placed at the Outset Hospital, and the staple line from his thoracotomy incision. But overall, there's no obvious pneumothorax or hemothorax in the chest. We go on to repeat a fast exam. And sorry, these will take a moment to load. In the right upper quadrant, we see that there is possibly some trace fluid in Morrison's pouch. In the pelvis, we see a moderate amount of simple anechoic fluid. And you can see here his Foley catheter in a decompressed bladder. When we move to the left upper quadrant, it doesn't appear that there's fluid in the abdomen in this view, but there is some anechoic appearing material above the diaphragm. And when we slide up a couple of rib spaces, we see that there is a large heterogeneous collection of fluid in the left chest. Compare this fluid density and complexity to the simple anechoic fluid in the pelvis. This fluid here is more concerning for blood. We go on to repeat a CT of the chest, abdomen, pelvis, and you'll see that there is a fairly large hemothorax in the left chest. Based on the Hounsfield's units, we were able to determine that there was likely blood. And when we get down to the pelvis, there is a small to moderate amount of free fluid in the pelvis. And these are some representative images. You can see the pleural fluid in the left chest here and the free fluid in the abdomen here. So we go on to place a left-sided surgical chest tube, and his post-chest tube x-ray pictured on the right compared to his pre-chest tube x-ray on the left, I think you can now appreciate in retrospect that this hemothorax was evident previously. It was just layering posteriorly, and so not quite evident, which just goes to show that a supine x-ray is really, has very poor sensitivity for detecting pleural fluid or pneumothorax. In addition, we performed a DPL at the bedside and determined that the fluid in his abdomen was neither blood nor urine. And he responded well to blood transfusion and was able to come off of all the vasopressors. Any questions so far about case 2? Sorry, Dr. Nordenholz, you were asking about the blood pressures.
Yeah, I'm just curious. I mean, did they change and that was forcing your hands to do further evaluation for ongoing shock, or because he's already on double pressors, right?
Yeah, it was the fact that he was on a fairly high dose of norepinephrine, a 0.16, and vasopressin, which was reportedly due to neurogenic shock, but that was kind of a higher dose and we were comfortable with, especially considering he just had flaccid lower extremities. It was a little bit out of proportion than what we would typically expect from a patient with pure distributive shock from a spinal cord injury. And yes, after blood transfusion, we were able to come off of those vasopressors.
Excellent pickup.
All right, so let's move on to case 3. This is a 45-year-old male who has COVID pneumonia and ARDS, is currently on heated high-flow nasal cannula with a blood pressure 80s over 40s. So our question is this distributive shock? Could he be hypovolemic, or could this be RV failure from ARDS? His IVC is seen on the left, is greater than 2 centimeters, collapsing a little more than 50% with inspiration, so his CVP approximately 8. And we can see on his apical forward chamber view of the heart, his RV may be a little bit enlarged, but the function appears grossly normal. And the LV does appear somewhat hypodynamic with some end systolic effacement, but the end diastolic volume appears fairly normal. And when we obtain an apical 5-chamber view and place pulse wave Doppler behind his aortic valve, we get a VTI measurement of 31 centimeters, which is several standard deviations above the normal for a male of 20 plus or minus 2. This man has a very elevated cardiac output, and this is all suggestive of a distributive shock case and a lack of afterload. So rather than being given additional fluids, especially given his tenuous respiratory status, he was started on vasopressors. His MAPS improved, and his VTI came down as well. That's kind of a quick one. Any questions about case 3? All right, we've only got 2 more cases here. One of them's a bit more complicated, so we'll draw this out a bit. Actually, we have 3 cases, I apologize. Okay, so case 4. This is a 60-year-old male with end-stage renal disease who is hemodialysis dependent. He presents dyspneic, hypoxic, and hypotensive. On exam, his lungs are clear bilaterally, and a chest x-ray is grossly unremarkable. His blood pressure, however, is still low after IV fluids. So our question is, could this patient have pulmonary edema? Is this tamponade? Is this a pulmonary embolism? Could this be heart failure left or right? His IVC is imaged on the left. I'm sorry, this is reversed from the usual convention of having the heart on the right side of the image. But you can see that it's greater than 2 centimeters with minimal respiraphasic variation. And on his apical forward chamber view, you'll notice right away that his right ventricle is extremely enlarged. It's over twice the size of his left ventricle, which is extremely diminutive with a reduced end diastolic volume. But clearly this patient is not hypovolemic. This is a case of left ventricular reduced preload due to right ventricular failure. We obtained some supplementary images. You can see the parasternal long axis view on the left. His LV is hyperdynamic with complete end systolic effacement and a reduced end diastolic volume, and this very prominent right ventricle. And on a parasternal short axis view, you can see that his left ventricle is quite diminutive. The interventricular septum is flattened during both systole and diastole, suggestive of right ventricular pressure and volume overload, and this severely enlarged right ventricle. We're able to place color Doppler over his tricuspid valve and see a fairly significant tricuspid regurgitation jet. And when we place continuous wave Doppler through this jet, we can get the velocity of the jet, which we can convert to a pressure gradient of 66 millimeters. And when we add his right atrial pressure estimate to that, which in him would be approximately 15 or 20, we can deduce that his right ventricular systolic pressure is about 86 millimeters of mercury, which is consistent with severe range pulmonary hypertension. The patient underwent a CTPA, which did not demonstrate a PE, and he was admitted to the medical ICU on a dobutamine and norepinephrine drip. He was given pulmonary vasodilators, and attempts were made to diurese this patient. But despite this, he succumbed to his decompensated right ventricular failure and pulmonary hypertension several days later. Are there any questions about case 4?
Did you have any information as far as like a pre-op echo on, or sorry, echoes prior to this echo?
You know, this patient, I think this was his first time in our system. We did not have previous echoes on him, and he was, he didn't have any operative trips, so we did not have a perioperative echo on him.
So obviously, the big thing also to remember is that this doesn't happen acutely, right? So RV to get that large with severe pulmonary hypertension had to happen over quite a period of time, and then there maybe have been some sort of exacerbation due to infection or whatever that kind of worsened his RV failure, volume overload.
Yeah, that's a great point. I mean, just because somebody has an echo like this, which clearly shows RV dysfunction and failure, does not mean that they're not also sepsis and that they shouldn't be given broad spectrum antibiotics. Though rather than fluid resuscitation, this patient really needed diuresis. And yeah, RV assessment is extremely nuanced. This is kind of a cursory overview of it. And at some point this year, we'll have to revisit that with another lecture dedicated to just RV, to evaluation of the failing RV.
And it really highlights kind of the clinical picture that you have to really keep in mind the clinical picture, because if you see an echo like this with someone that's completely normal, it could just be their kind of baseline, compensated heart failure. Whereas if someone is, coming in shocked, then obviously that needs something, some more attention. Yeah,
many of these patients with chronic RV or LV failure may have a dilated IVC at baseline, and that rarely is going to change. And they can certainly have distributive or hypervolemic shock.
Do you have a question, Vaughn?
Yeah, quick question here. Why dobutamine as a pressor in this patient?
I don't think there's great evidence one way or the other. I think epinephrine would have been just a fine vasopressor for this patient. With dobutamine, we do know that the afterload will tend to drop and you might get some worsening of your blood pressure, but as long as you have some sort of a vasopressor like vasopressin or Levophed on board prior to starting that to help support that map, then that should be fine. But I don't think anybody would fault you for starting epinephrine as a solo agent on this patient.
Yeah, it seems like your ability to improve ejection fraction is it's 0.
Yeah, I mean, his ejection fraction is 100%. So. All righty, so let's move on to case 5. So this is a 60-year-old female who was brought in by ambulance from a rehab facility for a fall from standing height. She suffered some facial trauma and en route had a low blood pressure of 72/50 with a heart rate of 88. Of note, she is 2 weeks out from an exploratory laparotomy from a small bowel obstruction. She undergoes a CT of the head and face, which demonstrates no traumatic injuries, and is found to have a white count of 15, though she's afebrile with a clear chest x-ray and no urinary symptoms. She's given IV fluids, however, intermittent hypotension recurs, and so she started on a low-dose norepinephrine infusion of 0.02. She started on broad-spectrum antibiotics and admitted to the medical ICU for sepsis without a source versus dehydration. You can see the imaging of her IVC on the left. It's greater than 2 centimeters with no respiraphasic variation. And remember, she's not intubated, so this is indicative of a CVP of approximately 15. And on an apical 4-chamber window, we see, similar to the previous patient, a very enlarged hypokinetic right ventricle. And you can also appreciate that there is a hyperechoic mass in the right atrium, which is intermittently prolapsing into the right ventricle. This is kind of a gimme case. This is a clot in transit, and this patient has a massive pulmonary embolism. She's admitted to the medical ICU on a low-dose norepinephrine infusion, but given its low dose, does not immediately receive thrombolytics, especially considering she's 2 weeks out from a fairly significant operation. However, during the night, she has escalating vasopressor requirements, becoming increasingly unstable, and so the decision is made to systemically thrombolyse her. Now, here we have on the left a peritoneal long-axis image prior to thrombolytics, and on the right, several hours after thrombolytics. You can see that if you estimate this with the eyeball, her left ventricular end diastolic volume prior to thrombolytics is extremely reduced, as her RV is not able to get that blood across the pulmonary circulation to fill this left ventricle. And after thrombolytics, you can appreciate that her left ventricular end diastolic volume has improved significantly, and she was able to come off of vasopressors with that intervention. Are there any questions about case 5?
Was there a discussion on either catheter-directed thrombolysis or an angiovac?
I think there was, but given her, I think she was up to 0.2 of Levophed and also requiring vasopressin. and this occurred around 3 in the morning. And so given her deterioration and the lack of resources at that time of day, the decision was made to proceed with systemic thrombolysis.
Yeah, no, that sounds appropriate if it's kind of a more urgent and deteriorating situation. But at our institution, we have the ability for angiovac, which is a venous basically bypass circuit with a filter. So basically, you just take blood out of the right atrium, maybe into the right ventricle using this catheter, and then that just kind of sucks the clot in, and then it gets trapped in this filter system. The other option is these ECOS catheters that we have also. The one interesting thing about the ECOS catheter, I don't know if you've ever done an echo while on an ECOS catheter, but it's a catheter that's left in place with kind of a TPA at the tip so that it causes the clot lysis, but also ultrasound waves to kind of shake up the clot. So it actually causes a massive artifact on your ultrasound image whenever you have an ECOS catheter.
Well, that's unfortunate. Another reason to dislike ECOS catheters.
Yeah, you can pause them for a minute though.
It will be interesting to see where the evidence pans out on these new modalities for treating pulmonary embolisms in patients who are submassive. However, for the patients with massive pulmonary embolism, I think it's important to also remind ourselves that there's really no good evidentiary basis for denying a patient systemic thrombolytics who's hemodynamically unstable unless they have a firm contraindication. Though that could certainly change in the coming years. Right now, the best evidence we have for these alternative modalities is from patients with submassive PEs that are high risk with significant right heart strain.
Yeah, I absolutely agree. And actually, a lot of times when we do these procedures in someone who is not as an extremis in a submassive, or a smaller PE, they actually kind of get worse during the procedure because there's kind of breakage of clot and more kind of systemic inflammation during the procedure itself.
Yeah, we'll have to do another lecture this year on some of the more nuanced assessments of RV failure from various etiologies. Okay, let's move on to case 6. And Trevor, thanks for sharing that article, the review article from Dr. Bull on Huntras. We're fortunate here at the University of Colorado to have several leading world experts in pulmonary hypertension, including Dr. Bull on Huntras. Okay, case 6. This is the last case, but it's going to be a good one. So this is a 30-year-old male with a past medical history of type 1 diabetes complicated by gastroparesis and cyclical vomiting syndrome, with frequent emergency department visits 3-4 times a week for this unfortunate state. He presents once again to the ED with abdominal pain, and on CT is found to have a midgut volvulus. He goes to the operating room for an exploratory laparotomy and has his volvulus reduced, and is found to have a large portion of ischemic small bowel, but it's not frankly necrotic. It's severely dilated. They're not able to close his abdomen, so he's left open. No resections are performed, and he's brought back to the ICU intubated. He also arrives on 0.18 of norepinephrine and 0.04 of vasopressin. So our question is this patient simply hypovolemic from third spacing, or could this all just be distributive shock from the expected significant reperfusion injury from his detorus ischemic bowel? His IVC is seen on the left, and you can see in the first part of the image, this is an aorta in the distant field. And then when we slide, we see here his IVC, which is completely collapsed down. And remember, he is intubated, so this is fairly sensitive for a low CVP state. And when we obtain his apical forward chamber window, his biventricular function looks reasonable. His RV is not imaged well here, but trust me, it was okay. And his LV and diastolic volume may be reduced, but it's not completely obvious. But when we measure it out formally, it's actually 58 milliliters. And recall that for a male of this age, 140 would be normal. And when we measure his LVOT VTI, it's also severely reduced at 11 centimeters. So this male has a low CVP, a low preload, and a reduced cardiac output. This is all consistent with hypovolemia. So he's given several liters of fluid, and his norepinephrine requirements do come down quite a bit, but then a point of diminishing returns is met, and he stops responding to fluid and actually starts to have a rising vasopressor requirement once again. And so his echo is repeated. And you can now see that his end diastolic volume has normalized to 112 milliliters. But on his apical 4 window, you can see that he has reduced RV and grossly reduced LV function as well. And when his ejection fraction was formally measured, it was about 15 to 20%. And this is a patient who has no previous history of heart failure. And when we measure his LVOT VTI, it's also reduced once again at 10 centimeters. And if we formally go through and measure his aortic outflow tract area, we get 2.03 centimeters, which once again is about 2 centimeters, giving us a stroke volume of only 32 milliliters, which when multiplied by his heart rate of 97 gives us a cardiac output of only 3.1 liters per minute, which if we divide by his body surface area, gives us a cardiac index of 1.6 liters per minute per meter squared, which is severely reduced and consistent with cardiogenic shock. And so based on this, the patient is started on dobutamine, following which his repeat echo, you can see on the left is apical 4. He now has much improved biventricular systolic function. And a repeat VTI has increased from 10 to 16 centimeters, which corresponds to a cardiac output of 5.9 liters per minute for an index of 3.1. So the patient is left like this and does much better overnight, has good urine output, and clears his lactate. Interestingly, this is a bit of an aside, but while the patient, before starting inotropes, a cardiology performed echo was obtained with definity contrast. And you can see here, the definity contrast is this lipid emulsion that makes the LV cavity light up with this bright white color. And it helps you visualize structures in the LV better and better assess the border of the left ventricular cavity to better assess for wall motion abnormalities or for the, and to better assess LV function and ejection fraction estimates. But what you should notice on these images is that there's this kind of complex anechoic structure kind of bouncing around in the apex of the left ventricle. This is a left ventricular thrombus in formation. And so this patient had to be started on a heparin infusion. Our suspicion is that this patient has a stress-induced cardiomyopathy from his severe reperfusion injury from this detorsed volvulus. And this thrombus is likely forming due to the stasis of blood in the LV, and hopefully will clear itself as his contractility improves. All right, so he does well overnight. However, the following morning, he has increasing vasopressor requirements again. And so our question is this patient in worsening cardiogenic shock? Can he be volume overloaded and now be needed diuresis? So on the left, you see his IVC, and he's intubated, so we can't conclude a whole lot from this. It does appear to be a little more than 2 centimeters, approximately. And then distally, you see it completely collapses down. But remember the clinical context. This patient has an open abdomen due to a severely dilated small bowel. And we had been measuring bladder pressures throughout the night due to his risk for abdominal compartment syndrome. And his bladder pressure at the time of this IVC image is in the high teens. So we would expect this IVC to be collapsed down, and we can't really make much conclusion about his CVP status from this image. Now his apical 4 window is repeated here. And sorry that it's a little bit undergained, but you can hopefully appreciate that his LV function may be mildly impaired, but looks grossly better than it was previously. So he's still doing better on dobutamine. We don't really see the RV very well, but trust me, it was okay. It was also about the same. And so the question is this, it doesn't appear that his cardiogenic shock has worsened, but could he, apologies, could he have some component of hypovolemia or distribution from his ongoing reperfusion injury, which we need to address? So to help distinguish between a low preload versus a low afterload state, we measure his end diastolic volume and find that it's reduced at 86 milliliters. Remember, normal should be about 130, 140. And concurrent to that, he still has a reduced LVOT VTI at 14 centimeters. So based on this, he's given additional IV fluids, following which we, in addition to that, we do a passive leg raise, following which we see that his left ventricular end diastolic volume appears better grossly, and we measure that in a moment. And on a peripheral long axis, you can appreciate the same. And also notice that this distal to the heart, you can see this anechoic fluid. This is a left pleural effusion, indicating that our patient has been third spacing fluid. So this is likely the reason why he's become relatively hypovolemic again. After the passive leg raise, you can see that his end diastolic volume has improved to 128 milliliters. And appropriately, his LVOT VTI has also improved to 17.5. So he's given additional IV fluids, and we're able to wean him off the vasopressors by that afternoon. Okay. Are there any questions about case 6? Well, that's the end of our talk today, and we can take any general questions this time. We have a little bit of time left.
Do not plant a raised bed garden.
Sorry, Dr. Bartels, can you say that again?
So first of all, that was a great talk. Congratulations. I think we all enjoyed it. You mentioned some of the pitfalls of jumping to conclusions when seeing a hyperdynamic ventricle and a low left end diastolic volume and pressure. At the bedside, what's like your first go-to, after assessing the history and maybe still not coming to a conclusion whether to prioritize volume versus tone?
I think that measurement of the end diastolic volume is really the crux for me. I think that, in severe extremes of physiology, if a patient is in gross hypovolemic shock, you'll be able to just tell that the end diastolic volume is severely reduced and that they need volume. But in kind of in-between cases, I do think it's helpful to formally measure it to really convince myself this patient needs additional volume. But I also think it's tough because patients can have relative hypovolemia from being in a distributive shock state. And as we know, vasopressors will squeeze those capacitance vessels, and so can help increase our left ventricular preload. So that's a tough one to answer, but I do think, yeah, it's important to recognize that complete end systolic effacement or that hyperdynamic kissing left ventricle does not distinguish between a lack of preload or afterload. If you combine that assessment with a formal measurement of the end diastolic volume and see that that is very normal, then that would be suggestive that this is purely an afterload problem and the patient really just needs a vasopressor. But in the former case where the end diastolic volume is still fairly reduced, that patient probably would benefit and certainly would tolerate fluid, but they may still need a vasopressor.
Thank you.
Bobby, great talk. This is Brendan Sullivan. Just wanted to mention that you mentioned it with the aortic insufficiency. I think also just a quick look at the mitral valve and tricuspid valve can help a lot, especially if you see a hyperdynamic ventricle, but it doesn't totally fit your picture. Sometimes the cause could be severe mitral regurgitation, or again, a hyperdynamic right ventricle with a dilated IVC could be a tricuspid valve problem. Not very common, but not uncommon in the CTICU or the cardiac surgery patient population.
Yeah, absolutely. Yeah, I think to really flush out this algorithm, doing some sort of a cursory evaluation for significant valvulopathies is certainly warranted, though I would not fault a more novice sonographer for excluding those. And I think, at the end of the day, some of those are going to be fairly esoteric and unfortunately I think are going to be missed a lot on the initial ED evaluation.
Did you have a chance to look at any of those new ultrasounds and comment on their kind of auto calculations at all, or do you have any experience with those?
I personally haven't played with the auto VTI modalities. This is quite compelling and I can't wait to experiment with those because I will admit that the actual manual tracing of the VTI can be a little bit cumbersome, especially with some of the machines. I find personally that the machines with the circular trackball, I feel like you have much better control over the tracing, whereas the ones that have the touchscreen, especially when you're wearing gloves and there may or may not be ultrasound gel on the glove or on the machine touchscreen, it can be challenging to accurately trace out the VTI. But yeah, certainly I'm interested by these auto VTI machines and would and I look forward to experimenting with those.
I had a chance to look at those machines this week, and it was both GE and Sonosite had these auto VTI functions, and they worked pretty well. You know, I think especially when you don't have a mouse and you're doing either a trackball or a touch screen, I don't think what I can do at least is any better than what the machine is going to do automatically. So I think it's a great modality, and I think that really points to kind of the direction.
Yeah, we saw the Sonosite PX and the Mindray TE7 with its new software, and both of those have auto VTI. There's an auto EF function on, I think it was the Mindrays also, that uses Simpsons.
Yeah, they work pretty well. And then great talk, Bobby, by the way. Really interesting cases and really relevant use of ultrasound for them. And I think the one other thing I'll highlight is that, all these cases showed kind of the value of doing serial exams.
Mm-hmm.
Even doing a daily exam on basically almost all ICU patients can potentially pick up, things that change. And especially if you've been doing the same exam, over and over on someone, you kind of notice small things that change that really help you in the management. So great work on that aspect as well.
Yeah, I completely agree. And I think it's really, especially in the ICU where we have the luxury of time and we can do more frequent reassessments of the patients, it's really critical to reevaluate their response to your interventions. And if their cardiac output or whatever parameter you're using is not responding as you were hoping, to reevaluate your strategy.
Mm-hmm. Excellent.
Okay, guys.
I think our time is up. Yeah. So thank you so much, Bobby, for doing this, and thanks everyone for attending. This is our first critical care ultrasound conference on Zoom, and it seems like it worked pretty well from an IT standpoint. So we will continue to do that for the rest of the year, imagining that these rules will not change for this academic year. So nice to see everyone, and look forward to seeing all of you guys next month.
Okay, thank you all for coming.
Great job, Bobby.